everyone, my name is Pravina Gautam and today I want to talk to you about something that I really think matter for all of us going to nursing, which is voluntary assisted dying or PAD. This is a topic that can feel uncomfortable to sit with, and that is okay. What I hope to do today is walk through you two things. First, real ethical tension around PAD, both the reasons people support it and the reason people have serious concern. And the second, what good care actually look like for the patient who choose this pathway. But now that is now legal access across every Australian state and territory, including the ACT. The Northern Territory is the only jurisdiction still working towards its own legislation with a framework expected. So this is no longer a distant debate. It is already a part of the healthcare landscape we are stepping into. So what exactly is PAD? At its core, it always allows adults who are living with a terminal or life-limiting illness to request medical assistance to end their life. But it is not something anyone can simply ask for. There are strict requirements. The person must have full decision-making capacity. They must be acting completely of their own free will, and they must be experiencing suffering that cannot relieved in any other way. The safeguards are also there by design. To walk through the ethics of this, I will be using 4 principal framework developed by Beecham and Childress. They are beneficence, non-maleficence, autonomy, and justice. As you can see on the slide, these 4 principles give us a consistent and structured way to look at PAD from different angles, and importantly, they do not point in the same direction. Let's start with beneficence, the idea that we have a duty to act in our patient's best interest. For many patients with serious illness, like palliative care does an incredible job, but it does not always reach everyone equally. For some people, no matter how good the symptoms management is, there is still a level of suffering, physical, emotional, existential, that feel unbearable for them. For those patients, PAD can offer something profound. It's a sense of control, of dignity, of not having to wait in fear for the end. What research also shows us is that choosing PAD doesn't mean walking away from the palliative care. Michael et al. Found no meaningful drop in care quality when PAD was offered alongside palliative support. And Moliner et al. Found that PAD patients in Victorian community setting were engaged with palliative service for more than double the time of the general patient population, a median of 101 days compared to 48. These are not patient abandoning care, they are patient using every option available to them. But then there is non-maleficence, which is do no harm, and this is where things get harder. Digby et al. Raise real and serious concern where the risks of total pressure being placed in vulnerable patient, the difficulty in accurately assessing whether some truly has decision-making capacity, and the moral distress experienced by the healthcare worker involved in the process. These are not abstract worries, but they are the things that happen, and this is the tension seat right at the heart of the PAD. And can intentionally ending a life ever truly be reconciled with the principle of doing no harm? There is no clean answer to that. Clinicians working in this space must hold both sides of the question at once, and that is genuinely difficult. Moving to autonomy, which is probably the principle that most powerfully support PAD. Respecting autonomy means respecting a person's right to make decisions about their own body and their own life, including how it ends. When someone has full capacity, has been fully informed, and has made consistent and voluntary decision overriding, that decision is itself a form of harm. White et al. Also show how PAD and advanced care planning strengthen each other. When patients start thinking seriously about the PAD, they also tend to have more open and meaningful conversation about their values and the goals and what matter most to them at the end of the life. The benefit everyone involved in the care. On the access side, Gender and Prince highlight that allowing nurse practitioner to conduct PAD eligibility assessment as the act now meaningfully improve access for the patient in rural and remote area who might otherwise never be able to see a specialist. But autonomy has limit too. Digby et al. Point out that depression, cognitive decline, or family pressure can all quietly undermine a person's ability to make a truly free, informed choice. How do we know when decision is genuinely autonomous? That's the question require ongoing careful assessment. And autonomy does not belong to patient. Nurses have their own values. Henning and Kyung found that nurses who objected to VAD on conscientious ground often felt uncomfortable and exposed, which required to rebuild deeply personal belief in professional environment. Their autonomy matters too. Under the legislation, nurses must refer patient who asks about VAD, but they cannot be forced into participate, and that balance is important as well. The principle of justice also asks to think about fairness where who get access. This is protected who might be left behind. Legally, VAD is now available to all Australian, but legal availability and the real world access are two separate things. White all found that people in rural and remote area face significant practical barrier, fewer trained provider, long travel, less flexibility. The law says yes, but geography can still say no. Faith-based health service add another layer of complexity. Digby et al. Reported that when institutions refuse to allow VAD on their premises, patients may be forced to transfer often at the point in their lives. When moving in distressing and disruptive, in communities where a faith-based facility is the only option nearby, that raises serious justice concern. So where does that leave us? VAD does every one of the principle, and no one of them give a simple clean answer. Beneficence relieve suffering, non-maleficence is be careful not to cause harm. Autonomy says respect people's right to choose, and the justice says make sure that the right is real and equal for everyone. These principles do not always pull in the same direction, and that is exactly what makes VAD one of the most ethically complex issues in contemporary healthcare. As Light et al. Remind us, passing legislation is just the beginning. The real work happens in clinics and in conversation and in the ongoing ethical reflection that good nursing requires. Now I want to shift the second part of this presentation. What does high quality care actually look like for someone who had chosen VAD? Because choosing VAD is not the end of life care relationship, it is the first part of it. The first thing is that the symptoms management must remain a priority, and the patient who has requested VAD still needs pain relief, comfort, and support right up the end. Michael et al. Confirmed that care quality stays stable when VAD is properly integrated into palliative pathway. Choosing this path does not mean care stop. Second, the legal safeguard matter and not just as bureaucratic process. Australian legislation requires multiple independent assessment, document and eligibility, and the formal review through the VAD review board. These are not hoops to jump through, they are the protection. And as nurses, our role is that process is to provide information openly without judgment. Patients need to be able to ask us questions and trust our answers are honest and not filtered through our own discomfort. Thought. This is one I feel strongly about. Psychological and spiritual support cannot be an afterthought. Hewitt et al. Found that patient families and healthcare staff all need emotional support throughout the VAD journey. It is not just patient going through this. Advanced care planning is the fourth pillar, and White et al. Are clear that it should be woven through the whole process. When patients have documented their values and goals, it helps everyone, including the patient, feel grounded in their decision. Staff education is the main fifth important one. It is non-negotiable. Light et al. Found a direct link between how well-trained clinicians felt and how confident, willing they were to provide related care. We cannot deliver good care area where we feel unprepared and unsupported. And the sixth, continuing community continuity. Moneder et al. Found that when community nurses present across the whole VAD process, from the very first assessment right through the patient death, it made a real difference. Patients were less stressed, family felt supported. That kind of continuity is not just is nice to have, it's part of what makes this care truly compassionate. What does all this means for us as a nurses? Honestly, it means that VAD will ask something of us professionally and personally. Some of us may feel comfortable participating, others may not, and this is a valid position what the law asks all of us. The patient can access information they need if one we walk alongside. What every one of us responsible for is this: making sure whoever is in our care feels safe, feel heard, and receive care. This is grounded in the evidence respect that does not change depending on whatever we support, bad personally or not. Now, to wrap up, bad, it's not a simple issue. I would be cautious of anyone who tell us it is. It sits at the intersection of our deepest values as the healthcare professional: relieving suffering, avoiding harm, respecting people of choice, and hardworking. Working towards a fairer system for everyone. What the evidence tells us is that when BAD is implemented thoughtfully and integrated properly into palliative care, quality of care does not drop. It can be strengthened. Molnar et al. But that only happens with robust governance, genuine workforce support, and the commitment to equity. As future nurses, we are going to be part of this. The most important thing we can do is go into it informed, reflective, and compassionate toward our patients, towards our colleague, and towards ourselves as well. Thank you for listening, and here is the reference that I have used for this presentation.